Hey guys, a great day to everyone. So today we are going to talk about pain and pain management. So this is one of the most important symptoms that a patient may feel and that we nurses need to attend to, since pain is that discomfort that we feel and we want to get rid of it, most especially or all the time, most of the time rather, immediately. So we'll begin with the discussion about pain. And pain is an unpleasant sensory and emotional experience arising from actual or potential tissue damage, or it may be described in terms related to such damage. This is from the International Association for the Study of Pain. So it's unpleasant. Anything that we feel, or it's unpleasant or discomfort, what because there is an actual or potential tissue damage. This is what we are feeling with regards to pain. It's somehow unpleasant. Sometimes it is unbearable for some of us. So it is whatever the person, or is whatever the person experiencing the pain says it is, existing whenever the person says it does. This is according to Margot McCaffrey, who is a nurse and a pioneer in the pain management. And according to Campbell, in 1995, pain is considered as the fifth vital sign. Most of the patients coming into the hospital, most of their complaints is pain. Pain mechanisms. We have nociception. It is the physiologic process by which information about tissue damage is communicated to the nervous system or central nervous system. We have our nociceptors, which is a free nerve ending that is a receptor for painful or noxious stimuli. So our tissues, let's say for example, our skin, if it detects an injury, if you had a cut, for example, so there is a tissue damage. If we get certain cuts or abrasions on our skin, the free nerve endings, which is the nociceptor, they will transmit this painful stimuli into the central nervous system. That is how nociception is, what nociception is all about. So we have different, as you can see here, different nerves that are supplying our skin. You can see there the free nerve endings. They're the ones who are detecting pain, heat, and cold. And you can see there that these free nerve endings, they extend up to the dermis of our skin. We have other nerves there, the Meissner's corpuscles, which are the ones sensitive to touch, Pacinian corpuscles for pressure. Ruffini endings are also for pressure. We have the root hair plexus, also for touch. Cross and bulbs, also for touch, and the Merkel discs, also sensitive to touch. But we are going to pay attention to the free nerve endings because the free nerve endings are the ones who are sensitive to pain. So there are four processes in pain. We have transduction, transmission, perception, and modulation. First one is transduction. This is the conversion of a mechanical, thermal, or chemical stimulus into a neuronal action potential. So anything that we detect or we feel, either mechanical, thermal, or chemical stimulus. Let's say, for example, mechanical. If you are, let's say, slicing vegetables, an onion or garlic, for example, and you accidentally cut your finger, that's mechanical. So it will stimulate the free nerve endings into a neuronal action potential. If we're talking about thermal, so you get scalded by boiling water, for example, while you're cooking or while you're frying your favorite fried chicken, and oil somehow got into your hot oil got into your skin. So this may be thermal stimulus or chemical stimulus. Let's say, for example, if an acid got into your skin, accidentally got into your skin, this will produce a chemical stimulus because there are some acids that can be irritating to the skin and can cause pain as well. It can burn the skin too. So noxious or tissue damaging stimuli causes cell damage with the release of the following sensitizing chemicals: the prostaglandin, bradykinin, serotonin, substance P, and histamine. Once these chemicals are produced, pain is going to be felt by the patient because these chemicals, once they are released, they will be or they are responsible for the production of pain. That's why there are certain NSAIDs that will help control these chemicals. So these substances, they activate nociceptors and lead to generation of the action potential for pain. So nociceptive pain, this is the pain produced from the activation of peripheral nociceptors. These are our free nerve endings. And once the action potential begins, this is the nerve conduction. This is how pain is being transmitted from the nerve endings on our fingers. For example, if you had a cut here into the central nervous system to our brain to interpret it. So once you get a cut and feel that pain here, it will travel through the action potential through our peripheral nerves, through our spinal cord, and reach to our brain. So it's the movement of pain impulses from the site of transduction to our brain. And there are three segments involved in the transmission. This is the transmission along the peripheral nerve fibers to the spinal cord. So peripheral, for example, you got a cut in your finger, it will travel to the peripheral nerves in our arms, going to the spinal cord. And once the pain transmission is already in the spinal cord, the dorsal horn of the spinal cord will process it, and transmit it to the thalamus and the cerebral cortex. So that is how pain is transmitted from the site of injury to the brain. So transmission to the spinal cord, there are dermatomes there. There are dermatomes rather on our skin that are innervated primarily by a single spinal cord segment. And you can see the illustration here. Those dermatomes, they are in accordance to a specific area of our spinal cord, such as T1, T2, T3, and so on. The legs or the thighs, as you can see here, they're in the lumbar area. So these are our dermatomes. Transmission depends on the nature of fibers, the afferent fibers that transmit this sensation. We have our C fibers, which are smaller unmyelinated nerve fiber and have slow pain transmission. We also have alpha delta fibers, which are large myelinated nerve fibers that have rapid pain transmission. So if we talk about C fibers, since they are unmyelinated, they have slow transmission of pain. For alpha delta fibers, since they are myelinated, they have rapid transmission of pain. Now we go to the dorsal horn processing. So once the nociceptive signal arrives in the CNS, into the spinal cord first, it is processed within the dorsal horn of the spinal cord. So here, the neurotransmitters involved in the transmission in the dorsal horn of the spinal cord are, we have the excitatory, the glutamate, aspartate, substance P. These are exogenous and endogenous opioids that bind to the receptor and block the release of neurotransmitters, particularly substance P. We have examples, the enkephalin, beta endorphin. These are the chemicals that are capable of producing analgesic effect similar to those exogenous opioids such as morphine. So these substances, like enkephalin and beta endorphins, they are produced by our body. And once they are produced in large amount, it can block pain. So it has a similar effect to morphine. We also have inhibitory. We have the aminobutyric, gamma aminobutyric acid, or GABA. We have serotonin and norepinephrine. So these are also neurotransmitters that are involved in transmission in the dorsal horn of pain. Now, it will now transmit this information of pain into the thalamus and the cerebral cortex of our brain. So from that dorsal horn, the nociceptive stimuli are communicated to the neuron in the brain through several pathways. What are they? We have the spinothalamic tract, or the neospinothalamic tract. This is a direct path from the spinal cord to the thalamus to the somatosensory cortex. And with this, since it says here it's a direct track, there is rapid conduction of the pain. So the location, intensity, and duration of pain is being transmitted, or being interpreted rather, by our cerebral cortex. The cerebral cortex will know the area or the location and how intense the pain is going to be. And we also have the spinoreticular tract, or the paleospinothalamic tract. This is a diffuse path from spinal cord to the brain centers such as the reticular formation, hypothalamus, and medulla. So it's slow because it doesn't reach the cortex, and it has several detours such as the reticular formation and the hypothalamus. That's why it has a slow conduction. So unpleasant emotional component and autonomic responses to pain are usually through the spinoreticular tract. So perception. This occurs when pain is already recognized by our brain, defined and responded by the individual experiencing the pain. So take note, perception happens too fast. There will be a reflex once pain is immediately felt by a person. And once that we have perceived pain, we immediately withdraw an arm or a hand or the foot from the pain source. Let's say, for example, you got cut. Our immediate response is to withdraw our hand from the knife that has caused the cut. Or you slam the door on your fingers. That is very painful. You immediately withdraw the fingers from it. Or you accidentally touch the hot surface of, let's say, for example, a sizzling plate. You thought it wasn't hot, so immediately withdraw your fingers from it. This is a reflex. So no single precise location where pain perception in the brain occurs. And there are several sites in the brain that will perceive pain. We have our reticular activating system. It is responsible for warning the individual to attend to the pain stimulus. So it will tell us that we need to attend to it. We also have somatosensory system, which is responsible for localization and characterization of the pain, whether the type of pain is a gnawing pain or a stabbing pain or a burning pain. So the somatory sensory system will interpret that for us. We also have the limbic system, which is responsible for the emotional and behavioral responses to the pain, and the cortex, which is responsible in constructing the meaning of pain. So the cortex is the one that will really interpret the whole thing that is happening with regards to the pain. Modulation. This involves the activation of the descending pathways to exert inhibitory or facilitatory effects on the transmission of pain. So it's descending now. It's going back. So it will go down. It's a descending pathway. So descending modulatory fibers release chemicals that inhibit pain transmission. So these are the chemicals that will reduce pain in the body. And they are produced by our own body. We have serotonin, our gamma aminobutyric acid, norepinephrine, and other endogenous opioids. This will help us with regards to the relief of pain. Pain threshold. This is defined as the lowest intensity of painful stimulus that an individual perceives as pain. So each individual has a different pain threshold. There are some individuals who are very sensitive to pain. So, meaning they have a very low threshold to pain. But for, let's say, for example, masochists, they love experiencing pain, so they have a very, very high threshold for pain. Pain tolerance, or the amount of pain a person is willing to endure. It's somehow similar to pain threshold, but here for tolerance, it's how you are going to endure pain. So how long are you willing to experience pain? If it's still tolerable, like a mild headache, you can go on for a whole day with a mild headache, you have a high pain tolerance. But if you have a mild headache and you want to attend to it immediately by taking NSAIDs such as paracetamol, then you have a very low pain tolerance. Classification of pain. So, comparison of nociceptive and neuropathic pain. For nociceptive pain, the definition is normal processing of stimulus that damages normal tissue and has the potential to do so if it is prolonged. Usually, nociceptive pain is responsive to non-opioid and or opioid drugs. So non-opioid, if you're only taking NSAIDs, for example, you can make nociceptive pain go away immediately. Now for neuropathic pain, these are abnormal processing of sensory input by the peripheral or central nervous system. Now, this type of pain is hard to treat. With with NSAIDs alone, you'll have a difficult time making the pain go away. That's why this treatment usually includes adjuvant analgesics, a combination of several types of analgesics such as NSAIDs, opioids, because this type of pain usually is it's intolerable, it is very painful, and it cannot be treated by the usual NSAIDs. Types of nociceptive pain, usually somatic. This arises from the bone, joints, muscles, skin, or connective tissue. Usually, the type of pain that is felt would be aching or throbbing in quality, and it is well localized. While for neuropathic pain, it is a centrally generated pain, deafferentation pain, or injury either to the peripheral or central nervous system. Let's say, for example, for phantom pain, usually phantom pain is felt by patients who had amputations of an arm or a leg, limb amputation. So they are sympathetically maintained pain. And it is associated with dysregulation of the autonomic nervous system, such as reflex sympathetic dystrophy. So here in neuropathic pain, there's a problem with regards to the peripheral or the central nervous system itself, unlike that of nociceptive pain. The types of nociceptive pain for visceral pain, this arises from the visceral organs, such as the ones for the GI tract and the bladder, and they can further be subdivided. Two more involvement of the organ capsule that causes aching and fairly well localized, and obstruction of hollow organs that causes intermittent cramping and poorly localized pain. So for example, if there is an intestinal obstruction that is occurring, you will experience cramping pain. Or if you have dyspepsia, you will also experience cramping pain because there is delayed gastric emptying there. So that is visceral pain. While for neuropathic pain, peripherally generated pain, there is painful polyneuritis. Pain is felt along the distribution of many peripheral nerves. Example, if you have post-herpetic neuralgia, so you had a herpes infection and it has involved the peripheral nerves. For example, you will experience this kind of pain. Diabetic neuropathy as well, or alcohol nutritional neuropathy. These conditions can cause painful polyneuritis because it will inflame these peripheral nerves. Painful mononeuropathies as well, usually associated with a known peripheral nerve injury, and pain is felt at least partly along the distribution of the damaged nerve, such as, example, nerve root compression. So let's say, for example, if your extremity is compressed for a very long time, you may have slept on it. Once you wake up, you will feel that there's pain on that affected arm. Or let's say, for example, you have trigeminal neuralgia. You will experience pain on the trigeminal nerve that is supplying some areas of our face. So you will experience pain as well from this. Classification of pain, differences between acute and chronic pain. The onset for acute pain is sudden, so it's immediate, while for chronic pain, it's gradual. So for acute pain, it suddenly spikes. But for gradual, there is gradual increasing intensity of the pain felt by our patient. For the duration in acute pain, it's usually less than 3 months, or as long as it takes for normal healing to occur. But for chronic pain, if it is occurring for more than 3 months, that is already classified as chronic and may start as acute injury or event but continues past the normal time for recovery. Usually cancer patients, they may experience chronic type of pain. For the severity, for acute pain, it's usually mild to severe. And for chronic pain, it's also mild to severe. Cause of pain for acute, generally, we can identify a precipitating event or illness. So if you have an illness, for example, or a surgery for post-op, you can know that you have pain immediately after surgery. But for chronic pain, it may not be known, or original cause of pain may differ from mechanisms that maintain the pain. Usually for patients who have neurologic disorders, and they need to be further assessed for patients who are experiencing chronic pain. Let's say, for example, for people who have migraine headaches. The course of pain for acute pain is usually decreased over time and it goes away as recovery occurs. But for chronic pain, typically it doesn't go away. And it is characterized by episodes of waxing and waning. So, like migraine headaches, usually disappears and then it appears again. Disappears, appear. There's even an aura to the migraine that will be felt by the patient. For acute pain, the physical and behavioral manifestations would reflect sympathetic nervous system activation. So the heart rate is going to increase together with the respiratory rate, blood pressure, there's diaphoresis, even pallor is exhibited by the patient. There's anxiety, agitation, and confusion and urine retention as well. But for chronic pain, it's predominantly behavioral manifestations are exhibited by the patient, such as having flat affect. So imagine talking to a patient who has constant migraine headaches. They will talk to you like a robot because flat affect is a person has flat affect sounds like they don't have an emotion at all. They talk like a robot. So they have decreased physical movement or activity. They are experiencing fatigue and they will withdraw from other people on social interaction. So take note, going back there, for acute pain, more of sympathetic nervous system activation. Chronic pain, it's more of behavioral. Goals of treatment for acute pain. Pain control with eventual elimination. So here, we just need to treat the underlying cause for acute pain. But for chronic pain, pain control to the extent possible, we are going to focus on enhancing the function and quality of life of the patient, especially if the patient is experiencing a neurodegenerative type of disease. And some neurodegenerative diseases really do not have a cure. Pain assessment. Pattern of pain. We need to know when it has started, the pain onset. So we are going to ask what time it has started. Pain duration, establishing how long the pain has lasted. So how many days or how many hours now? This helps to determine if the pain is chronic or acute. Pain breakthrough. This is transient, moderate to severe pain that occurs beyond the pain treated by current analgesics. So most patients who have cancer usually experience this type of pain. So it's not usually treated by the common analgesics, the NSAIDs. Episodic, procedural, and incident pain. It's a transient pain, increase in pain that is caused by specific activity or event that precipitates the or anything that precipitates the event of pain. Example, dressing changes or movement. So there are certain movements that will further cause more pain on the patient. Let's say, for example, if you have headaches and you're going to constantly move your head, of course, the pain is going to worsen. Or if you are eating, for example, there are certain types of ulcers that will be worsened by eating. Position changes as well can further worsen pain, or procedures such as catheterization will cause pain. Since in catheterization, pain, usually anesthetics are not administered to patients who will undergo catheterization or other invasive procedures such as injections. So this is procedural type of pain. Area of pain, we need to know the location where the pain is felt by the patient to identify causes and treatment. So typically the pain information about the location pain is asked. Describe for the site. Point, let the patient point to painful areas and mark painful areas on a pain map. So that is very, very important. We need to ask our patient where the pain is originating from. Referred pain is the spread of pain to areas far from the origin of the disease part. Example, if you have a liver disease, let's say you have hepatitis, which is located in the upper, right upper quadrant of our abdomen. And if you have a liver disease, this usually will be referred or radiate to the anterior and posterior neck region, so here, or the posterior flank area. Or another, if you are experiencing myocardial infarction or heart attack, the pain is usually felt here in the left side of the chest. It can be referred to the left shoulder, the jaw, the neck, even the arm, left arm of the patient. So that is referred pain. Intensity of pain. So we are going to assess the severity or intensity of pain, which provides a reliable measure that is used to determine the type of pain as well as its effectiveness. So we are going to ask the patient to, to measure the intensity of the pain that the patient is feeling. And these are helpful pain scales that we can use in order for the patient to further describe the intensity of pain that they are feeling. With the numerical rating scale, the Wong-Baker Faces scale, the verbal graphic rating scale, and the pain aid scale. We'll start with the moderate rating scale. This is very easy. So we are going to ask the patient to rate the pain intensity on a scale of 0 to 10. With 0, as you can see here on this illustration, meaning there's no pain, or 10 is the worst possible pain that the patient is going to feel. So the scale can also be simplified by using a scale of 0 to 5, but usually we are using 0 to 10. 1 to 3 as mild, 4 to 6 as moderate, and 7 to 10 as severe. Okay. For the Wong-Baker Faces scale, we are usually using this to younger children. And this uses faces to help describe the intensity of pain among pediatric clients, most especially those who cannot read or have a language problem. So we are going to explain how this is done and give meaning to each of the face. For example, for a happy face, it means 0, there's no pain for that. For a mildly happy face, 2, which hurts a little bit. For a neutral face, 4, it hurts a little more. For a slightly frowned face, it hurts even more. For a face that is already frowning a lot, it hurts a whole lot more. So that's 8. While for a crying face, it's the worst type of pain that the patient is going to feel. It's rated as 10. So you let the patient choose which type of face that according to the intensity that the pediatric patient is currently feeling with regard to pain. Now we go to verbal graphic rating scale. Words are used here along a continuum that describes the intensity of pain from no pain to worst possible pain. The scale can be modified using words that are better understood by the patient. So here words are used by the patient to identify the intensity of pain. Now we go to the pain age scale. This scale rates breathing, negative vocalizations, facial expression, body language, and comfort. This is especially useful in assessing the pain for patients with dementia, most especially for patients that we really are having a hard time communicating with. Because patients who have dementia, for example, you really cannot get useful information from them. So here, we're going to rate the following. Breathing independent of vocalization, 0 if there's normal breathing. If there's occasional labored breathing or short period of hyperventilation, it's scored as 1. For noisy labored breathing, long period of hyperventilation, and there are Klein-Stokes respiration, there's gradual increase in the rate of respiration and a period of apnea, so that will be graded as 2. For negative vocalization, if there's none, it's 0. If there's occasional moan or groans or low level of speech or negative or disapproving quality, that would be graded as 1. If they have repeated trouble calling out, they will always say it's painful, nurse, it's painful. There's loud moaning, groaning, or even crying. The patient is already crying because of pain. That would be graded as 2. Facial expression is the face of the patient still smiling or inexpressive of pain, 0. But if they are sad, if the face looks frightened, for example, if they frown, so they appear sad, you score 1. But if there's facial grimacing, you can note that if the patient is already crying, that's graded as 2. For body language, if the patient appears relaxed, it's 0. If the patient appears tense, or there's stressed pacing, or there's fidgeting, that is 1. Now, if the patient appears rigid, the patient constantly clenches his or her fists, or clenched rather, his or her fists. The knees are pulled up, or because of abdominal pain, for example, or this pulling or pushing away, or striking out. If you're trying to comfort the pain, that is 2. Consolability, there's no need to console, 0. If they are distracted or reassured by voice or touch, it's 1. So if you touch the patient and the patient was distracted by it, it's 1. But if you are not able to console or reassure the patient, that is 2. So 0 again is the lowest score, meaning there's no pain. 10 is the highest score, meaning that they have severe pain. Now we go to pain quality. This refers to the nature or characteristics of the pain. Example, neuropathic pain is usually described as a burning, numbing, shooting, stabbing, or itchy sensation. So that is neuropathic pain. while for nociceptive pain, it usually may be described as sharp, aching, throbbing, or camping pain. That's why we need to ask our patients the quality of pain that they have. Let's say, for example, if they have abdominal pains or stomach ache, we ask the type of pain that they are feeling, the quality. If they say that, nurse, I have a burning type of pain. Usually for a burning type of pain felt with the stomach ache, that is usually associated with, say for example, ulcers, gastric ulcers, or GERD, or gastroesophageal reflux disease. What if they have, let's say, an aching pain, for example, that may be differentiated from, let's say, indigestion, or they have dyspepsia, for example, or they have a lot of air or gas in their GI. That's why we need to let the patient identify the quality of pain in order to identify what kind of disease that the patient probably has. Now we go to the drug therapy for pain. First, we talk about the non-opioids. The aspirin, acetaminophen, and NSAIDs. This is indicated for mild pains such as headaches, stomach aches, joint pains, and so on. So I've mentioned these drugs earlier: acetaminophen, aspirin, and other salicylates and NSAIDs. These drugs are usually over the counter, so you don't need a prescription to buy them. And these agents are characterized by the following. There is an analgesic ceiling to their analgesic properties, that is, increasing the dose beyond an upper limit provides no greater anesthesia. So they do not produce tolerance or physical dependence, unlike that of the opioids. And like what I've said, they are over the counter. So we have the following: aspirin, choline, magnesium trisalicylate or trilysate. We also have the acetylsalicylic acid. We have acetaminophen, or the brand name is Tylenol, and other NSAIDs such as non-selective NSAIDs, ibuprofen, indomethacin, ketorolac, diclofenac, the COX-2 inhibitors such as celecoxib and valdecoxib. So the non-opioids, the choline magnesium trisalicylate or trilysate, the effects of this is antipyretic, analgesic, antiplatelet, and anti-inflammatory. Side effects include gastric upset, platelet dysfunction, and bleeding. That's why it's very, very important for giving aspirins to patients who have, let's say, for example, problems regarding blood clots. If they are prone to develop blood clots, they need to be given aspirin as well, because it has antiplatelet properties. And we nurses must take note of its side effects, gastric upset, that this type of medication should be taken in with food. So patients should eat food first before taking aspirins, because they can irritate the gastric mucosa since it is an acid. For acetaminophen, it has both an antipyretic and analgesic effect. It's contraindicated to patients with liver disease or those who have alcoholism. For non-selective NSAIDs, they have both anti-inflammatory and analgesic properties. And side effects include impairment of renal functioning, bleeding tendencies, GI upset, and ulceration. That's why some of them, such as mefenamic acid, they need to be taken in with food. Again, for COX-2 inhibitors, The effects are anti-inflammatory and analgesic as well. Adverse effects are risk of adverse cardiovascular effects, myocardial infarction, strokes, and heart failure. That's why patients should not avoid COX-2 inhibitors because it has a potential risk to our cardiovascular system. So for the NSAIDs, they inhibit the enzyme cyclooxygenase, or COX. We have COX-1, which promotes gastric and renal blood flow and platelet adhesion, and COX-2, which is produced mainly at the sites of tissue injury where it mediates inflammation. So COX-2 is an inflammation mediator. Next, we go to opioids. So for opioids, we have the mu agonists, the mixed agonist antagonists, and the partial agonists. So opioids, they are indicated for moderate to severe pain, most especially those who are experiencing, let's say, for example, cancer or any neurodegenerative disease. The effect of this is the inhibition of transmission of nociceptor input from the periphery to the spinal cord. So it stops the transmission of pain from the periphery itself. And there's altered limbic system activity as well, and activation of the descending inhibitory pathways that modulate the transmission in the spinal cord. So we have the mu agonists, we have the morphine, hydromorphone, methadone, levorphanol, fentanyl, and oxycodone. We also have the mixed agonist antagonists, such as penthazocrine, butorphanol. We also have partial agonists, such as buprenorphine or buprenorphine plus naloxone. These opioids, their side effects, or we'll start with the new agonists. Side effects are sedation and respiratory depression. The respiratory rate is less than 12 cycles per minute. We need to withhold the medication and contact the physician. There's no analgesic ceiling for this. For mixed agonist antagonists, side effects are dysmorphia and agitation, withdrawal, dependence, and produces less respiratory depression than that of the new agonists. It also has an analgesic ceiling. Well, for partial agonists, have limited availability and clinical value in pain management. They are rarely used for these types of drugs or opioids. Opioid to avoid nowadays is meperidine or Demerol, because this one is associated with neurotoxicity. It can cause seizures because of the accumulation of its metabolite normeperidine. So meperidine is contraindicated for patients taking monoamine oxidase inhibitors, those who have depression, and taking MAOIs, because it can lead to hyperpyrexic syndrome with delirium. So the patient's body temperature is going to shoot up if you give both meperidine and MAOIs to the patient. You'll learn more about monoamine oxidase inhibitors while you are going to discuss the antidepressants in psych nursing. Side effects of opioids are the following. The most common opioid side effect is constipation. That is why we need to attend to this. We either give a gentle stimulant laxative, such as Senna, or a stool softener, such as docusate sodium, cholase, or bisacodyl, dulcolax, or lactulose, Dufalac. Or we need to encourage the patient to eat foods that are high in roughage or fiber. So fruits and vegetables. They need to eat a lot of those if they are taking in opioid analgesics, and lots of fluids and exercise as well in order to stimulate the passage of stools. Other side effects include nausea and vomiting, since opioids delay gastric emptying. So to treat nausea and vomiting, we are going to give the patient an antiemetic known as metoclopramide or Reglan. So metoclopramide is given to reverse nausea and vomiting from the patient. Now, one of our nursing responsibilities always, whenever we are giving morphine or any other forms of opioids to the patient, is to check for the patient's respiratory rate because it can cause respiratory depression. Now, if the patient has experienced a respiratory rate of below 12 cycles per minute, the doctor is going to prescribe opioid antagonists such as Narcan, naloxone, to reverse respiratory sedation and accompanying acute overdoses of opioids to ameliorate other opioid side effects. So 0.4 milligrams of naloxone is added to 10 ml saline solution and it can be administered IV or sub-Q in 0.5 ml increments every 2 minutes. That is why when we are giving opioids to patient, the emergency drug at the bedside should always be naloxone, just in case the patient's respiratory rate drops below 12. So patients who are at risk for respiratory depression include the following: the elderly, those with underlying lung disease, like say for example COPD, or those who are receiving other CNS depressants such as sedatives, benzodiazepines, and antihistamines. That's why these two drugs, opioids, together with these drugs, sedatives, benzodiazepines, and antihistamines, they are not given together because it can cause severe respiratory depression. Other side effects include pruritus or itching. We will give antihistamines to patients in order to reverse the effects of pruritus. So, or the patient will need or switch to another form of an opioid if it is necessary. Tolerance is characterized by the need for an increased opioid dose to maintain the same degree of analgesia. Another side effect would be physical dependence, most especially for patients who have been exposed to using opioids for a long time. So if there's ongoing exposure to pharmacologic agents or opioids that is manifested by withdrawal syndrome, that occurs when the blood levels of the drug is abruptly decreased. That's why physicians, they will not immediately stop the delivery of opioids to our patients. Our doctors need to gradually reduce the dosage of opioids to or for our patients. Addiction, it's a complex neurobiologic condition characterized by a drive to obtain and take substance for other than the prescribed therapeutic value. So if the patient is already addicted to it, they will look for it every day. That's what we are trying to avoid here. Contraindications: if the patient has head injuries, opioids are not given because respiratory depressive effects of these medications can lead to the accumulation of carbon dioxide, and cerebral blood vessels will dilate and can cause an increase in intracranial pressure. Or patients who have shock. These medications or opioids can decrease also the blood pressure of the patient, especially if the patient has a hypovolemic shock. And the co-analgesic or adjuvant drugs, we have first, the drugs that are indicated for neuropathic pain or combination with either or both non-opioids and or opioids. We have antidepressants. These are adjuvant drugs to pain. They enhance the descending inhibitory system by preventing cellular reuptake of serotonin and norepinephrine. Remember, serotonin is also responsible for the relief of pain. That is why for depressed patients, this is given in order to increase the serotonin in the inhibitory system in the CNS. Because patients who have depression, the theory here is that they have a decreased level of serotonin. Side effects would be anticholinergic side effects such as dry mouth, urinary retention, sedation, orthostatic hypotension. Weight gain and sexual dysfunction is also present. Examples would be amitriptyline, Elvil, imipramine, tofranil, nortriptyline, Pamelor. You will learn more about these tricyclic antidepressants in your psych subject. We also have the selective serotonin reuptake inhibitors. Again, it will increase serotonin levels. Example would be paroxetine or Paxil, sertraline or Zoloft, and fluoxetine, hydrochloride, or Prozac. Other drugs that is used to treat pain would be anti-seizure drugs or anti-epileptics. They both affect the peripheral nerves and CNS through sodium channel modulation, central channel modulation, and changes in excitatory amino acids. So they can be helpful to reduce pain as well, such as carbamazepine, Tegretol, or gabapentin or Neurontin. And corticosteroids, they are also given to decrease edema and inflammation to relieve pain. But they should not be given at the same time with NSAIDs because NSAIDs are already anti-inflammatory. Corticosteroids are also anti-inflammatory. Examples of these drugs are dexamethasone or Decadron, prednisone, methylprednisolone, or Medrol. So corticosteroids, they will reduce inflammation and edema, therefore it will relieve pain from the patient. Local anesthetics can also be given to interrupt the transmission of pain signals to the brain, such as lidocaine. This is administered through the transdermal route. Side effects would be cardiac conductivity problems, dysrhythmias, and myocardial depression. That's why we need to monitor the patient's heart rate if we are giving lidocaine. Mixed mu opioid agonists and NE5-HT reuptake inhibitor. This also inhibits the reuptake of norepinephrine and serotonin, such as Tramadol or Ultram. Side effects of this drug would be nausea, constipation, dizziness, and sedation. Another, for patients who are experiencing chronic forms of pain or those who have, let's say, those who are admitted to have severe type of pain or demand analgesia every now and then, they need to be having this, the patient-controlled analgesia. So it is connected to an epidural catheter where a dose of opioid is delivered when the patient decides to need that dose. So PCA or patient-controlled analgesia uses an infusion system in which the patient pushes a button to release or receive a bolus infusion of the analgesic. So the patient needs to be assured that he or she cannot overdose because the pump is programmed to deliver a maximum number of doses per hour. So it is this PCA is programmed on how much the patient is going to receive or how much analgesic the patient will receive. Pressing the button after the maximum dose is administered will not result in additional analgesic as well. So that's how PCA is maintained. Okay, now we go to this, the interventional therapy. There is a regional anesthesia that the doctor is going to apply. So these are nerve blocks that involve one-time or continuous infusion of local anesthetics into a particular area for pain. These usually are for cancer patients. We have neurolytic celiac plexus block. This is done for pain caused by pancreatic cancer. So that is neurolytic celiac plexus block. If the pain is caused by post-thoracotomy, or the thorax is opened, let's say for surgeries involving the lungs or the heart, there will be, or the surgeon is going to perform intercostal neurolytic block to minimize the sensation of pain in that area. If the patient has a vulvar cancer, the doctor is going to do a pudendal nerve block, because the patient usually, the female patient will usually feel the pain in the vulvar area. We have other neuroablative techniques. These are performed for severe pain that are unresponsive to other therapies, such as opioid analgesics. So here, the doctor then destroys the nerves, thereby interrupting the transmission of pain. First, we have chordotomy, wherein neurosurgical procedures that ablate or destroy the lateral spinothalamic tract. So once that part of the spinal cord is destroyed, the transmission of pain is interrupted. For rhizotomy, this type of surgery now destroys the sensory division of a peripheral nerve or a spinal nerve, such as this. They destroy the peripheral nerve in order to prevent the transmission of pain. And lastly, for tractotomy, this is the surgical severing of the nerve tracts, especially in the middle of the brain, which is typically to relieve intractable pain or mental illness and research. So here, the medulla of the brain is the one that is involved in tractotomy. So that's it, guys, for our topic on pain. If you have any questions with regards to our topic, please do not hesitate rather to send me a message. I will answer you with the best that I can, and wait for our next topic. Again, have a great day. Thank you.